9, 10. Hi, I'm John Reed, and I'd like to welcome everybody here today. We're doing chronic kidney disease with Dr. Aleksandra Golovine as our speaker today. This is sponsored by HFA and the Blood Brotherhood. So before we get started, I'd just like to cover a couple of little webinar points and helpful hints. The webinar is a tool that provides you the opportunity to learn and engage, and we invite your participation, but we won't be taking questions until the end of the presentation. Dr. Golovine's presentation should be about 45 minutes, and then we should have 15 to 20 minutes at the end of that to take questions. Anytime that you would like to submit a question in the chat box, you can go ahead and type one in at any time, and we will accumulate those, and Michelle and I will relay those questions for you. If you are on the phone option, you will be given the opportunity to give those questions orally. We welcome your participation. The audio will be muted on your end after we have opened up the system. So today's presenter is Dr. Aleksandra Golovine. She's an assistant professor of medicine at the University of Texas, Houston, of renal diseases and hypertension. She works mostly as a transplant nephrologist, but also for patients with chronic kidney disease and patients with end-stage disease on dialysis. She is also involved in the medical education of medical students, residents, and fellows. Thank you again for joining us, and at this point I will turn the presentation over to Dr. Golovine.
Thank you, John. My name is Aleksandra Golovine, as John said. I work over at University of Texas, Houston. I do mostly transplant nephrology, but I do also a lot of chronic kidney disease. And what we'll be talking about today is how chronic kidney disease relates to patients with hemophilia. Namely, first talking about what do kidneys do, what is the definition of chronic kidney disease, what can cause it, and then what are just specific points in patients with hemophilia as far as it relates to chronic kidney disease, and we'll be talking about HIV and hepatitis C. So to begin, what do kidneys do? I just wanted to first show a picture of the kidneys. They're actually about the size of the fist. They are located right under the rib cage in the back. They are attached to tubes called ureters, which drain urine from the kidneys. The kidneys produce the urine. The urine is drained through the ureters into the bladder, and then, of course, peed out. They pretty much clean blood and get rid of fluid. That is really their purpose. So they remove the waste products produced by the food we eat and drink. They remove excess fluid that we eat and drink, and these things are removed by urine. So urine has water in it, and then all that excess waste that we need to get rid of. So the healthy kidneys, ideally, filter about 50 gallons, and that is converted to about 180 liters of blood. They reabsorb 49.5 gallons, and they excrete about half a gallon, and that's equal to 1.5 or 2 liters of excess waste. This is urine in a 24-hour period. So if you want to divide that into minutes, that's about, so you're basically dividing 180 liters into 24 hours. That's about 125 mils per minute of blood that is filtered in a 24-hour period. And this is what we call the glomerular filtration rate. This is how we measure kidney function. That 125 is ideal. Not everybody is born this way. And we believe that anything over 60 mils per minute is pretty good. Now, after 30 years old, filtering decreases by about 0.8 milliliters per minute. So this person that started out at 125 mils per minute when he or she reaches 70 years old, that person can expect to filter at 93 mils per minute. And this is somebody who, of course, started out at 125. So if you start out at a little bit lower, you're obviously, as you age, going to have lower filtering. So how does filtering work? Well, it's a very complex process. So it involves reabsorption of the fluid that is the blood, basically, that is filtered through the kidney. A lot of it, most of it is reabsorbed. It involves secretion. Some of the waste products are secreted actively into the urine. And then finally, excretion of the waste product, which is the urine. And salt, potassium, calcium, phosphorus, and acid balance is regulated this way. And many drugs are also metabolized this way, and that's why it's important to know what drugs you're on when you have kidney problems, to know if they're being adjusted accordingly to your kidney function. So I just wanted to show a picture of this filtering unit. The filtering unit is called a nephron, and the kidney has millions of these. And each nephron has this little red blob that you see there called the glomerulus. This is the filter. So the blood goes into the artery, and actually the glomerulus is made up of a lot of arteries. So the blood that has a lot of waste in it goes into this glomerulus, and then any waste product that needs to be excreted or secreted out goes through all these tubules, and that's that yellow tube stuff. Goes through all of that. That's where the secretion process and reabsorption process happens, and finally whatever needs to come out comes out as urine. So what else do kidneys do? They also produce hormones that regulate blood pressure. They produce hormones that regulate the production of red blood cells, and they produce active vitamin D that helps keep bones strong. What is chronic kidney disease? So basically, malfunction of the kidneys characterized by either a structural defect in either of the kidneys, some kind of electrolyte imbalance in the blood, or blood or protein in the urine because it should not be there, or a decline in filtration function. And this is going to be down to less than 60 mils per minute in a 3-month period or longer. So the malfunction can be local and affect one kidney, and usually it's this way, it's systemic and it affects both kidneys. And I just wanted to say once again, if your glomerular filtration rate is over 60 mils per minute and you do not have a structural defect, you do not have an electrolyte imbalance, and you do not have blood or protein in your urine, you do not have chronic kidney disease. You have normal kidney function. But if you have a structural defect, electrolyte imbalance in the blood, or you have blood or protein in the urine, and your glomerular filtration rate is over 60, you can still say you have chronic kidney disease. So if your glomerular filtration rate is less than 60, no matter what, you have chronic kidney disease. So the malfunction in the kidney function results obviously in decreased filtration, and that affects your salt, potassium, calcium, phosphorus, acid, and fluid balance, all the things that the kidney does. Because of that, you have high blood pressure, and that's mainly because you retain salt and you retain fluid. You also can have high potassium because the kidney is responsible for excreting potassium, and it's the kidneys, and they don't do it as well when they're chronically diseased. So you can have high potassium. This can be actually deadly. If it's high enough, it can stop the heart. So this is something we get very nervous about. We monitor this closely. You can get a high amount of acid in the blood, and this can weaken the bones and cause heart dysfunction. You can also get low calcium, level in the blood and high phosphorus levels, and this results in weak bones and vascular and heart disease. You also, because the kidney is involved in producing a hormone that helps make red blood cells, you can get decreased red blood cell production, resulting in anemia. And because the kidney makes active vitamin D, if your kidneys are diseased, they don't make enough of it, and you can have weak bones. So there's a lot of things that the kidneys affect when they don't work well. I just wanted to show the stages of chronic kidney disease, how we as nephrologists look at this. So like we talked about, stage 1 and 2 is this glomerular filtration rate, 60 to greater than 90. If you do not have a structural problem or blood or protein in your urine or an electrolyte problem, you do not have chronic kidney disease. Even though you have a glomerular filtration rate that, let's say, is 61. Now, anybody less than 60 mils per minute does have chronic kidney disease, and it starts with stage 3, which is 30 to 59 mils per minute. Stage 4 is 15 to 29 mils per minute, and finally, stage 5 is less than 15 mils per minute. So the less than 15 mils per minute stage is where we start thinking about dialysis. Just because you reach less than 15 mils per minute does not mean that you automatically need dialysis. It just means that at that point, some people may need it. And the way that we figure out how you need dialysis is based on how you feel, meaning do you have a good appetite? Are you losing a lot of weight? Are you having a lot of nausea, vomiting? So kind of evidence of not handling the waste products as well systemically. We also look at your potassium values. Are you able to handle potassium, or is your potassium increasing and therefore it's getting dangerous, and because of that you need dialysis? We also look at the acid status. So some people can actually last without dialysis for a very long time and still be less than 15 mils per minute. It's very individualized. And as you can see, as far as prevalence goes, most people end up in this stage 3 chronic kidney disease, and very few progress to stage 4 and 5. And so our goal as nephrologists is to figure out how we can stop progression. And we'll talk a little bit about how we think we can do that. As far as CKD demographics, so about 14% of people in the United States have CKD, and of that 14%, these are the ages of them. So about 5% are 20 to 44 years old. About 13, 14% are 45 to 64 years old, but 44% are over 65. So CKD does affect older people, and CKD is chronic kidney disease. As far as men, about 10% are, 11% are male, and 12%, I guess, are female. And then here are the race, the way that they break down by race, as far as white, black, and African American. So the majority are still white. Causes, the number 1 cause is type 2 diabetes. Number 2 cause is hypertension. And if you look at the pie here, I mean, diabetes is 43.8%, so a tremendous amount of people have chronic kidney disease because of diabetes. 26.8% have it because of high blood pressure. And really the third one that we look at is this glomerulonephritis, and I highlighted it because this is the one that applies to patients with hepatitis C and HIV. And we'll talk about what exactly glomerulonephritis is. The fourth reason is inherited diseases. The most common is polycystic kidney disease, which is inherited from your parents, basically. And then number 5 is malformations of the kidney in the womb. So what is glomerulonephritis? Remember we talked about how glomerulus, and if you look to the right, there's that little red dot thing. That's the filter, and it's made up of arteries. So glomerulonephritis is inflammation of that filter. And that inflammation can be caused by the person's own immune system, cancer, or infection. So as far as own immune system, usually that's a disease like lupus nephritis. So any lupus can cause glomerulonephritis. Cancer is usually things like multiple myeloma, sometimes lymphoma, and then there's finally infection. And the most common infections that cause glomerulonephritis are hepatitis C, hepatitis B, HIV, and then there's some bacterial infections that can do it. And here we have the main infectious causes of glomerulonephritis. So HIV is very common cause of glomerulonephritis, and the estimate is 7 to 30% of patients with HIV have chronic kidney disease. Hepatitis C can cause it, hepatitis B, and then these are the 2 most common bacteria, Streptococcus and Staphylococcus, that cause glomerulonephritis. So as far as what kind of glomerulonephritis does HIV cause, it causes this, and this is what we call it, collapsing focal segmental glomerular sclerosis. And this is also called HCV, and that stands for HIV-associated nephropathy. And this usually occurs in advanced disease, and more than 80% of these patients have a CD4 count of less than 200. And this is a very recent finding. We see it mostly in people of African origin who have these polymorphisms of this APOL1 gene on chromosome 22. So what does that mean? They have some kind of mutation of this gene that leads potentially, we think, to susceptibility to glomerulonephritis if there is another problem. So the other problem in this case is HIV. And we think that this mutation came about because people with this mutation are able to combat a certain tropical disease much better than people who don't have it. So we think that's why, and the tropical disease is trypanosomiasis, or African sleeping sickness. We think that's why this mutation has survived in our gene code. But unfortunately, it's not very good in people who already have diseases that may affect the kidney. And in this case, it's HIV. And the good thing about HCV is that it can, in some cases, be prevented with highly active antiviral therapy. And sometimes it can potentially reverse. The highly active retroviral therapy can reverse some HCV. So in general, all HIV patients should have their kidney function, and what does that mean? That means they should have a basic metabolic panel. So that panel involves sodium, potassium, your acid balance, this thing called chloride, something called BUN, which is a marker of how well you clean your blood, and creatinine, which is another marker of how well your kidney functions. So they should have that checked initially on diagnosis of their HIV, and then no matter what, every 6 months. They should also have their urine checked for protein initially on diagnosis and then every year. And the reason that's important is because this HCV, this glomerulonephritis associated with HIV, is detected or suspected when you're seeing a lot of protein coming in the urine, when the glomerulus is spilling this protein that it shouldn't be spilling. So if an HIV patient is on the drug tenofovir, they have to have their kidney function, of course, checked initially on starting the drug, and then in 1 month, and then no matter what, every 4 months, because tenofovir specifically has been known to cause toxicity to the kidney. And what it hurts is, remember I'm going to go back to the diagram of the nephron, which was that filtering unit right here. So those yellow tubes that you see, the tenofovir hurts the beginning portion of those yellow tubes, and it poisons them. And so initially what happens is the patients cannot reabsorb their potassium or their bicarbonate in those tubules because they are poisoned, and they spill it in their urine. These patients have what's called Fanconi syndrome, and this is just the spilling of potassium phosphate, uric acid, bicarbonate that this tube is supposed to reabsorb. Sometimes, if this happens for a long time, it can cause scarring of that tubule, and that is when you get chronic kidney disease with tenofovir, and you have to discontinue the drug, of course. So that's why it's important to be checking kidney function. And like I said, part of kidney function is also checking this potassium, acid-base balance, all those other things, so that you can be clued into the fact that this tenofovir might be poisoning this tubule. So as far as hepatitis C and hepatitis D, so these viruses can cause two types of glomerulonephritis. One is called a membranoproliferative, and the other is called a membranous, and this is diagnosed by kidney biopsy. And fortunately, they can be treated by simply treating hepatitis C and hepatitis B, and those are and we don't have to go into the therapies of hepatitis C and B, but if they do become resistant to treatment, we can use certain chemotherapy drugs that target the immune system. And we're often pretty successful treating these. Now, patients with hepatitis C and hepatitis B should have their renal function and urine studies. And what I mean by urine studies is really looking at a urinalysis for protein in blood, monitored every year. So how is chronic kidney disease diagnosed? Well, unfortunately, when it is early, it's kind of difficult to diagnose it. It's very non-specific. So people present with some high blood pressure. If they get their urine checked, they'll have protein or blood in the urine, but you have to check the urine first to do it. A lot of the times it's microscopic, so they themselves don't notice it. So if you do have a lot of protein in your urine, your urine will get frothy and bubbly sometimes, but that's when there's a lot of protein there. So it's quite difficult to diagnose it early based on clinical signs. That's why it's important to just regularly have your kidney function checked. It can be diagnosed late. That's when it really comes out, because by that time people are anemic. They have very low blood calcium levels, high phosphorus levels, high acid levels. They don't feel good. A lot of the times they'll have symptoms of nausea, vomiting, appetite loss, cramps, things like that. And the symptoms are also late in the disease are swelling and shortness of breath, because they're not able to pee like they used to, so the fluid builds up in their legs and their lungs. Interestingly, they urinate more frequently at night because the kidney, the function to hold on to water is not as good in the kidneys, and so they just spill water. And of course, people wonder, well, then why do people swell if they're just getting rid of water all the time, not being able to hold on to it? Well, it's because they hold on to salt. So they don't spill the salt, they just spill the water, and the salt causes swelling, actually accumulation of fluid in the legs and the lungs. People have loss of appetite, weight loss, nausea, vomiting. They can have itching, and this is caused sometimes by the high phosphorus in their blood or simply by the waste products that accumulate in the skin. There's easy bruising of the skin because people don't clot as well. They're very tired, and some people can have bone pain. Can it be treated? So yes, it can be treated. So simple, just chronic kidney disease, not really talking about what caused it, but just how to manage your chronic kidney disease, the simple things you can do. You need to keep your blood pressure less than 130 systolic over 80 diastolic. That's kind of the best blood pressure that the kidneys like. You need to be under a less than 2 gram per day sodium diet, and that could be converted into less than 5 grams per day of sodium chloride intake, which is salt. So that's important, and that's really important for blood pressure control. And then control of protein excretion in the urine. So I wrote here goal of less than 150 milligrams in a 24-hour period. The kidney doctor can check for that specifically. The way that we do it is through something called a urine protein creatinine ratio, where we take just one urine sample, and from that we take a protein level and a creatinine level, and we divide it, and that gives us our ratio. So we want that to be less than 0.15. And that really preserves kidney function. The way we can do that, too, is there's drugs out there called ACE inhibitors. There's also drugs called ARBs. The ACE inhibitors usually end with IL, so some of the most common ones are enalapril, lisinopril, captopril. The ARB drugs, the most common ones are losartan or Cozar or Diovan. Those drugs specifically decrease the amount of protein that a person excretes. And so if the protein levels are greater than this 150 milligrams in a 24-hour period, we will put patients on those drugs to make sure that we can get their protein excretion down in their urine. Good control of diabetes is key, and the goal is to have this hemoglobin A1C, which is a measurement of how well your diabetes is controlled in a 3-month period. We want this number to be less than 7%. No matter what, we want you to stop smoking. Smoking really does contribute to decompensation of kidney function. And we do recommend 30 minutes 5 times a week of aerobic exercise. Believe it or not, it actually does contribute to more healthy kidneys, also much better blood pressure control. We really want people with chronic kidney disease to avoid excessive NSAID use. So NSAID, that stands for non-steroidal anti-inflammatory drug. These drugs are things like Aleve, naproxen, ibuprofen, Motrin, high-dose aspirin. We're okay with baby-dose aspirin, 81 milligrams. Those drugs can injure the kidneys, so we do not recommend using those drugs when you have chronic kidney disease. As far as pain goes, we recommend, if you're going to do over-the-counter, Tylenol. And then drink plenty of water. And actually there have been studies that show that if you drink more than 2 liters a day compared to someone who drinks less, your kidney function will end up being better later on in life. So drink, and this is just water, not any other fluid. Drinking water really does preserve kidney function. So when should you see a nephrologist? And the nephrologist is a physician who specializes in kidney disease. Not to be confused with a urologist, who is a surgeon who specializes in the urinary tract, okay? So when do you see a nephrologist? When you have a sudden drop in kidney function. So you go to your primary care or infectious disease doctor, they say, wow, all of a sudden your kidney function's really gotten worse, and they will tell you this either by saying this creatinine number or BUN number got higher, or your filtration went down. If they tell you that and it's sudden, it's worth seeing a nephrologist about. When your filtration rate falls below 30 mils per minute, it's worth starting to see a nephrologist to manage your other issues. Because probably by this time you will have higher blood pressure, maybe some issues with acid balance, potassium, things like that. If you consistently are having more than 500 milligrams of protein in your urine in a 24-hour period, so that means a urine protein creatinine ratio of greater than 0.5, if you're having this, it's worth seeing a nephrologist to figure out why that's happening. And you may require a kidney biopsy for this. If you have unexplained red blood cells in the urine, worth seeing a nephrologist. You may require a kidney biopsy for that. And this is also because glomerulonephritis, remember that inflammation of the glomerulus can manifest as protein in the urine, but it can also manifest as blood in the urine. And if you have known chronic kidney disease and high blood pressure that is resistant to treatment with 4 or more blood pressure medications, it is worth seeing a nephrologist, because nephrologists also are experts in managing blood pressure, more so actually than cardiologists. If you have recurrent or extensive kidney stones, you should be seeing a urologist, which is the surgeon for the urinary tract, but you should also see a nephrologist, because they might be able to figure out exactly why you're having those stones and maybe give you a diet that could potentially prevent making more of them. And then if you know that you have hereditary kidney disease, and this is usually this polycystic kidney disease, you should be seeing a nephrologist. So I just wanted to talk a little bit about kidney replacement therapy. So what does that mean? Remember, when your glomerular filtration rate falls below less than 15 mils per minute and you start having really bad symptoms of kidney disease, like the nausea, vomiting, the bad potassium that can't be controlled. And what I mean by that is you cannot control it with diet. You cannot control it with medications. There's laxatives that we sometimes give people to try to keep their potassium low. So when you're having symptoms like that, we say, you know what, you need some kind of kidney replacement. So in other words, something to help clean your blood and get rid of fluid, because your kidneys aren't doing a good job anymore. Kidney replacement does not affect your current kidney function. Your kidneys will do whatever they're going to do, but they're at a point where they can't do enough to keep you healthy, and so we add this replacement. So the first one and the most common one in the United States is hemodialysis. So this is dialysis, and dialysis is basically cleaning and removing fluid from the blood. So this is dialysis done directly through the blood, and as you can see, this man, if you look at his left arm, he has what's called an AV fistula, which is which is the safest way to dialyze somebody. And what they do is they put one needle in the arm, and blood is taken from the body through that needle, through the tube, into the machine, and it goes through a filter. And you can see that filter all the way to the right there, that tube filled with blood. That's a filter. That's a fake glomerulus. That glomerulus filters or cleans the blood. The machine also takes fluid from the blood that the person can't pee out, and then the blood is recirculated back into the patient through another needle in their skin. The quickest way to gain dialysis access actually is through a catheter, but because that can be placed right away. But the safest way is this arterial venous fistula, which is a surgeon has to create that. They take the artery and the vein, and they attach it together, and it takes about 3 months to mature. That's hemodialysis, which obviously In people with hemophilia is complicated because it would require factor replacement, things like that, maybe with each treatment. It's kind of an individualized therapy. So what most nephrologists recommend for hemophiliacs is peritoneal dialysis. So this is dialysis through the belly. So the actual membranes in the belly can serve as a filter. And what we do is we infuse, and this usually happens at night when a person is sleeping, though you can do it during the day, but you infuse fluid filled with sugar into the belly through this catheter that a surgeon places. And the fluid sits in the belly for a couple of hours, and because it has sugar, it draws fluid from the rest of the body into it. So that's how you take care of the fluid, and it cleans the body as well. So, and then you get rid of the extra fluid after about 2 hours. And so what you do is these exchanges. So you do about 4 of these exchanges, so that takes about 8 hours. So that's why people like to do this at night. And this seems to be more safe in hemophiliacs because there's no direct blood contact into a blood vessel. This is also something that you do every night. You do it on your own, so you can be more independent. You just have to see your nephrologist once a month, whereas hemodialysis, you do 3 times. If you're going to do it in center, you do it 3 times a week for 4 hours. You can do it at home as well. And you can shorten your treatment if you do it at home. Ideally, we like, if we had it in an ideal world, we would recommend hemodialysis daily, probably for about 2 to 3 hours. Finally, there's kidney transplant, and we think this is really the best kind of kidney replacement. You can qualify for a kidney transplant when your glomerular filtration rate is less than 20 mils per minute. So you can get a kidney from a dead person, or when you have to sign up on the list for that, or you can get it from a living person who wants to donate to you, and that could be anybody who is your blood type. If you have a friend, let's say, who wants to donate but is not the right blood type, there are now programs in most transplant centers called kidney exchange programs, where they will find a patient and donor who also are not matched, and you can just switch. Your friend can give their kidney to that other person, and that other person's donor can give a kidney to you if you guys are the right blood type. We think this is really the best type of kidney replacement. It offers you a better quality of life, and it really offers you 24/7 clearance, whereas the others only give you clearance either, with hemodialysis 3 times a week and peritoneal dialysis only at night. So this is a constant clearance, and people really do live longer with transplant than people on dialysis. And I do want to say that with kidney transplant, I know our center at University of Texas, Houston, the hospital we use is Memorial Hermann, does transplant hemophiliacs. So anyway, that's the end of my presentation. Does anyone have any questions?
Okay, Michelle, are people that are on the call going to be able to just ask their questions?
There's a lot of
Are you there?
Yeah, I'm there.
We're technical difficulty. Axel, Alex, are you still there?
Excuse me?
Yeah, are you still there?
I'm there, yeah. It's just there's a lot of echo coming from you.
Is it from me? Is it from me? Michelle, why don't you read this question?
Can you hear me?
Yes. Yes.
Okay. Okay. Are there any questions?
Yeah. I do have one.
You know, I can't hear you very well at all.
Can you see the questions on the question and answer?
Okay.
Hello?
Yes.
Okay. The question is, at what glomerular filtration rate value does toxicity start to build up to cause enough, I'm trying to read this as I go here,
Okay.
to cause physiological symptoms?
So, you know, usually it's below 20 mils per minute, honestly. So it's pretty late into the disease.
Okay, and then his
That's
second...
that's why we really want people to check their kidney function often.
Okay. His second question is, what are the common symptoms during stage 5?
The most common symptoms are going to be lack of appetite, a lot of nausea, sometimes a lot of weight loss, muscle wasting, fatigue, itching.
Okay. I have another question that says, are there any contraindications in taking K-exolate prophylactically once a month if your K values are around 5.8 to 6 due to chronic kidney?
So, you know, usually you should probably, I don't know how often the values are 5.8 to 6, but probably once a week is better than just once a month. And K-exolate is that laxative that helps you get rid of your potassium in the stool, actually. So I would say maybe going to once a week and then having the labs monitored to see if it's keeping the potassium in the 5. Once it starts going above 6, that's when it's more dangerous.
Okay. And I don't have any way of getting feedback from these people, so I don't know if they had any follow-up.
Oh, okay.
Michelle, if you're still out there, do we have any other questions, or are there questions that people can just chime in with?
Yes, John, there are some questions, and I just sent some questions over. Also, I sent a message to the audience, but if you haven't seen it, please submit your questions via the question box, and we'll be able to share those with Dr. Golovine.
Okay.
Thanks.
Let's see what else I've got here. It says, we as hemophiliacs usually see blood in the urine. Does that mean that we should be worried?
Well, that's a tough question. I think that means that you basically need to have your kidney function maybe monitored at least once a year. You know, it depends on your risk factors. If you're a person with hepatitis C, B, or with HIV, then you should monitor your kidney function, like I was saying before, more frequently. If you have high blood pressure or diabetes, risk factors for chronic kidney disease, you probably need your kidney function monitored maybe twice a year. But if you don't have any of those and you just have hemophilia, then probably you're fine. you know, but it's hard to tell. So it's probably good to at least once a year have the kidney function checked.
Okay. The next question is, which doctor should be doing the kidney test? GP, ID? Should you actually be seeing a nephrologist?
So, so if you have an infectious disease doctor because you already have, you know, the HIV, Hep C, then your infectious disease doctor should be doing it. But if you know, if you're infectious disease, and sometimes you of course have to be your own advocate. If you see, hey, my kidney function's gotten worse from last time, you probably need to say, you know, I want to be referred to a nephrologist. Now, if you just have a GP or hematologist because you don't have HIV or Hep C or any other infectious disease, then, you know, it's kind of the same thing. You have to kind of sometimes be your own advocate, looking at the lab, saying, wow, my kidney function got worse, and then asking your physician to refer you.
Okay. It says, what clotting factors are underproduced with advanced HCV, and why are clotting factors underproduced with
we're talking, okay, advanced HCV, so hepatitis C virus. So I'm assuming that this is probably cirrhosis now that we're talking about. So cirrhosis is kind of end-stage liver disease. So if you have bad hepatitis C that is now causing cirrhosis of your liver is responsible for producing most of your clotting factors. And actually, patients with hemophilia can be cured by a liver transplant because the liver produces those factors. But of course, it doesn't just produce, it produces many. And so as your liver declines in function, it cannot produce all those factors. And so therefore, you get more and more trouble with clotting.
Okay. Wow, this is a long one. Hang on just a second. Is there, okay, it says, okay, and you may have already answered this. Is it safe to take K-Exolate once a week?
It's safe to take it once a week, but honestly, if you're on K-Exolate, you need to have a plan as far with your doctor who's giving it to you of how often you should get labs. And in the beginning, you should probably be getting labs more often. I would say maybe once a week to kind of see if the K-Exolate is working. And then, you know, if you notice, hey, it's working, you can just slow down on how often you get labs.
Okay. And I might explain to folks that K-Exolate is a drug that's given to reduce your potassium when you have.
Yes, exactly. So it's a laxative that makes you waste potassium in your bowel movement.
Right. Okay. It says, is there any particular dietary habit that you would recommend to people with hemophilia in order to prevent kidney disease?
So people advocate for more of a low-protein diet because the kidneys have to work harder to excrete protein. But you don't want to become malnourished. So if you do not have chronic kidney disease, I would not change, I would not go on a low-protein diet. If you have chronic kidney disease, you could consider a low-protein diet. And there's a website called the National Kidney Foundation, NKF, that has more information on how to decrease protein in your diet. Now, everyone should stick to a low-sodium diet. That is probably, all of us should do that, because that really decreases high blood pressure and that decreases your risk of kidney disease. And that's at less than 2 grams of sodium in a day.
Okay. Does losartan make you more prone to dehydration?
Okay. No.
It says I drink many times the amount of fluid that my wife drinks and really seem to need that fluid. No diabetes. our brother's the same way, drinks constantly, and goes to the bathroom a lot. No HIV in this case.
So I'm sorry. So the question is, does losartan cause the person to urinate a lot and be dehydrated?
Or to become dehydrated, right?
Okay. So no, actually, because losartan is not a diuretic. Okay. So losartan, what it does is changes kind of the way that the glomerulus filters blood. So it does not involve increasing the amount of fluid that is excreted by the kidneys. So losartan should not cause that. Now, diuretics can, and those are pills that make you pee out extra water, and that'll be things like Lasix, furosemide, hydrochlorothiazide, metolazone, or Zeroxylin. Those are usually the guys that cause dehydration.
Okay, and losartan is made with preparation with hydrochlorothiazide, so he might.
There is a preparation of losartan with hydrochlorothiazide called Hyzar.
Right.
But losartan by itself is also available. So if losartan is with hydrochlorothiazide, then yes, the hydrochlorothiazide portion of it can cause you to be dehydrated.
Okay, let's see what else we got. Can we get a copy of this presentation? You probably don't know the answer to that.
I would be happy to give you guys that. And I think Michelle actually has this presentation. Okay, I gave her the copy in April.
And I think it's going to be, I think that actually this webinar will be up on the website. Okay, he says, I went on a low-protein diet, dropped 6 pounds in 2 months. How can I recover my weight? Can I consume more fatty, sugar-containing foods? I am not a diabetic.
You know,
and this is somebody with stage 5. This is somebody with stage 5.
Stage 5?
Right.
Okay, and I guess the question is, are you on dialysis? Because if you're on dialysis, then you should not be on a low-protein diet anymore.
I can tell you that he is not. He is not on dialysis.
He is not. Okay. Okay, so what I would do, because this is a very specific question, I would honestly, I'm assuming this person probably has a nephrologist.
Yes.
And they should seek, and that nephrologist should be able to give them a consult with a nutritionist who specializes in chronic kidney disease, and that person could help him, you know, exactly tell him what to do. The National Kidney Foundation website also has information on that. But I don't know how much the person weighs or if they truly are underweight, so we would have to take that all into account. Also, if somebody's losing a lot of weight when they're stage 5 and they're not on dialysis, it could be that they now need to be on dialysis because their kidneys don't function well enough to keep their weight up, and they're having a lot of muscle wasting. So I think that should be a detailed conversation between the patient, the nephrologist, and a nutritionist.
And Alex, you can verify this, but something that just came to me on that losartan question, because since losartan is a ACE inhibitor, a lot of people
an ARB.
Have a persistent dry cough that is
okay.
That is
so
associated with
actually,
that, and that could be causing them to be thirsty.
Yeah, except losartan is not an ACE inhibitor. It's an ARB, so it will not cause the cough. The cough is caused by ACE inhibitors like enalapril, lisinopril, those drugs. The losartan should not cause the cough.
Okay. One question that I had when you were giving your presentation, when you were talking about the prevalence of chronic kidney disease with people with HIV, what my take from that, and you correct me if I'm wrong, is the most prevalent people were people that actually have active HIV and have CD4s of below 200 or are on tenofovir. Is that correct or incorrect?
So those are the most common.
Those are the most common people to develop chronic kidney.
Except, and that's specifically to HIV, except now, of course, because patients with HIV are living pretty normal life expectancy, they now develop diabetes and high blood pressure. And so that's a lot of reason they're getting chronic kidney disease. But HIV specific, it's the low CD4 counts and the tenofovir population.
Okay. I'm not seeing, and I'm not seeing any more questions at this time. So do you have any final thoughts for us?
Well, I think, people get very scared about chronic kidney disease, but it is of course a chronic disease, and you guys obviously are experts in that, handling chronic disease. But it's a doable disease, and if you have a nephrologist and you keep up to date, and really the National Kidney Foundation website is an excellent resource. You can be, a lot of the times you can make it without dialysis, and you could be okay. So, a lot of people kind of see it as a death sentence, and it's not.
Okay, I did have one final question here, and regarding that, would you recommend if you have Hemophilia, would you avoid in HIV, would you avoid tenofovir if possible, or if it is?
I would.
You
I
said
would
yes,
avoid
you
it
would.
if possible. Yeah, I would have a very, candid discussion with my infectious disease doctor, and really talk about the risks and benefits. But I would try to avoid it. Yeah.
Okay.
I would try at least.
Okay, if we don't have any further questions, I certainly appreciate your time and your talent and your effort today. Michelle, do you have anything else?
Nothing else here, Don, but thanks everyone for joining us.
Oh, yes. Thank you very much.
Thank you. Thanks.
Have a great weekend, everyone.
Okay, then
All
we're
right,
going to be
thank you,
signing
Michelle.
off. And this will be available
goodbye.
on the website. I'll let you take over the details of where they can find the transcript for this.
Yes, this will be available via the website. In addition, we also have we'll have slides or handouts from this presentation, so we will send those out to you via email. But again, thank you for joining us, and watch the Blood Brotherhood page of the HFA website to find upcoming events, whether it be webinars or online chats. We hope you can join us. Thanks.
Okay, thank you very much.
Thank you. Bye.